You'll remember that we've made a number of visits to the practice of osteopath Emmanuel Samut, and we've seen him treat a wide variety of patients, but this next one, I have to say, surprised me. A lady with osteoporosis, which she swore only got better after Emmanuel had laid on the hands. How does he do it? Osteopathy is perhaps the most significant contemporary epidemic that GPs are asked to manage. According to the National Osteoporosis Society, the average GP practice will have at least 140 women affected or at risk of osteoporosis. At the age of 80, half of the women will have sustained an osteoporotic fracture. Osteoporosis, though, doesn't just cause limb fractures, it also causes collapse of the vertebral bodies with a loss of height, compression of the contents of the chest and abdomen, impaired mobility and reduced quality of life. Well, we're back at the practice of osteopath Emmanuel Samut this time to discuss with him the contribution which osteopathy can make to these patients' management. Emmanuel, from the osteopathic point of view, what are the main features to consider in osteoporosis?
The main changes are the changes that occur in the spine. As a result of osteoporosis is often associated scoliosis. And we also monitor the changes in the gait. If we're going to be looking at the patient over a long term, we want to ensure that the gait doesn't become too forward weight-bearing and too far forward and shuffly in its character.
And this is one condition that you would have an X-ray for, is that right?
Yes, that's certainly one condition. Unless the patient has been referred by the GP with a diagnosed osteoporosis, then I would ensure that the patient hasn't got an underlying vertebral collapse, and before actually starting a treatment program, I would request an X-ray from the GP just to see what the case is before I started.
Now, the GP obviously has quite a positive role in osteoporosis. We can prescribe HRT at the menopause, we can prescribe HRT and the bisphosphonates and possibly calcium and vitamin D in later life. What's the role of the osteopath?
I see my role as managing that patient that is suffering with osteoporosis. I'm not too concerned with the osteoporosis as such, but as the secondary effects of osteoporosis. That's primarily, as we said earlier, is their postural change and their effects on gait. So we're managing the person suffering with osteoporosis. Okay, Mary, I'll just be having a look at you as you're standing there, just to keep an eye on how the changes and the curves getting on. So just running through here and just checking on the curve, on the scoliosis. And just tip your head up a little bit for me. Is that comfortable?
Yes.
That's fine, just hold it there. Just have a look. Have you had any leg pains this week?
No, they've been all right.
It's been okay. Okay.
Mary, tell me a little bit about yourself.
Well, I'm 65 years of age, and about 8 years ago I was diagnosed as having osteoporosis.
What was wrong with you at that time?
I had a lot of spinal pain, I had a lot of hot flushes, sweats. In fact, I felt very uncomfortable.
So your GP did an X-ray?
That's right. Unfortunately, I didn't go straight away because I was embarrassed about the whole thing. But when I did pluck up courage, he did the X-ray, and from that, they found I had osteoporosis.
And what did he suggest?
Well, he suggested going on to HRT, also having manipulation, and suggested the osteopath. And I thought, well, I may as well have a go, because I just wasn't getting any better.
Let's have a look at your walk now. So if you can nice and slowly walk up to the window, and then when you get there, just turn round and come back towards me.
What do you think of Zimmer frames that some of these old ladies end up on?
I'm not keen for two main reasons. Once you actually give a patient a prop, such as a stick, a tripod or a Zimmer, they feel psychologically defeated because they've got that and they feel they can't get out without it. And secondarily, I'm aiming actually to keep their gait upright and their posture upright. Once you give them an object to lean in front of them, they will inevitably start going forwards, which actually defeats the object of my approach.
Now, we've got a model spine here. Can you show us how you'd use it?
Yes. Now, I like to use a spine in order to initially show the patient what a normal spine should look like, so indicating the normal curves and the lordoses, working my way up towards the kyphosis. And then what I try and do is simulate the shape that she has as a result of her osteoporosis. Now, in Mary's case, we have quite an advanced curve in the thoracic area. And the reason for this is when I'm educating the patient in terms of what to do to prevent symptoms from occurring, I try to indicate the ways that her body would like to move, i.e. if she can only rotate to the left, and make sure her household chores would go centre to left, as opposed to aggravating her symptoms by going towards the right. So it's really an educational tool. It's very visual, and the patient can actually get an idea of what's going on with themselves.
So she's really a pretty typical case of osteoporosis.
She is, yeah. Okay, I'd like to have a look at you side on, so if you could just turn to face me a little bit. That's fine. Okay, any tummy troubles?
No, I know my chest goes on my stomach. But
Yeah, okay. Have you had
apart
any
from that,
breathing difficulties, shortness of breath, anything like that?
yes, I can't do very much for a very long time.
So if a patient like this came to see you, how would you assess her initially?
My initial assessment would be to watch her standing posture. My aim is to make sure that her posture stays as upright as possible within her condition, and also analyse her gait to prevent her from typically falling forwards. So I would watch her stand from the side to ensure that there's not too much anterior weight bearing. I would observe her from behind to just watch any curves, any spinal change of spinal curves. I would then ask her to perform some very simple active movements like bending forwards, bending backwards, bending to the side, to either side, and then I would proceed to assess her clinically in a passive way. So she would perhaps sit down, and I would then carry out the passive movements of her spine to give me an idea what's actually left in that spine, what ranges of movements are still there, which gives me my potential improvement and prognosis for the case. Just going to go a little bit further just to encourage a bit more movement there.
Right.
That's good. Any problems with that?
No, that's okay.
And what specifically would you then do to manage the case in the longer term?
In the longer term, I would carry out the physical treatment, and I would give a lot of advice on how to carry out her normal day-to-day chores. I would ask the patient a lot of questions as to what is particularly aggravating, what she can't do, and work around that. But what's also important is to alleviate fears that they often come in, such as they begin to feel short of breath, or they start to get in problems with their tummies, and that's often because of the actual shape changes. A shortness of breath can easily be advised by helping her to breathe properly, teaching her how to take deep breaths to make sure she's got her spine nice and upright, to indicate to her how she can expand her ribs more. If they're getting disturbances in the bowels, that's often because of compression of viscera, so that can be incorporated in the general advice and management.
How important do you actually see it is to communicate with general practitioners in a case like this, which very clearly has a medical component as well as a physical one?
It's important to keep in touch with the GP, particularly if they're being referred in the first place, and perhaps on a long-term basis, every couple of years or so, would like a new X-ray to see whether we have any degeneration occurring, any new changes, or perhaps, as it sometimes occurs, there's a spontaneous collapse vertebra and the patient isn't even aware of it. Once it's X-rayed, it's then brought to light.
What do you think coming to an osteopath does for you?
Well, it does keep the bones and the muscles all flexing. And in between, I do get rather set. So I am pleased to come and be relaxed again. And I can walk better than I could before I came. So that speaks for itself.
The National Osteoporosis Society has estimated that in the UK only 2% of sufferers from osteoporosis receive any treatment at all. Yet it's a condition which leaves sufferers frail, frightened and at considerable risk. It's a condition whose significance has not yet been taken on board by most of our profession, yet it's one which, if it's to be managed effectively, will need integrated preventive and treatment strategies from a whole host of healthcare professionals. Osteopathy may be only one part of that picture, but it obviously has a valuable role for at least some of our most vulnerable elderly patients.